Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
It is my pleasure to introduce my guests for today, Dr. Alvaro Iborra and Dr. Manuel Villaneuva. Dr. Villaneuva is an orthopedic surgeon in Madrid, Spain, and Dr. Iborra is a podiatric surgeon and professor in Madrid as well. Because this episode is so technical and the video and 3D medical illustrations that Dr. Iborra and Dr. Villaneuva have are so integral in understanding the complexity and the beauty of what they're doing, I strongly recommend that you tune into this episode in video. Dr. Iborra and Dr. Villaneuva have been so kind to host me in Madrid when I was there, and I was able to see them actually perform these procedures not only in the cadaveric lab but with patients, and it's really phenomenal what they do. They have to be the world's experts in diagnostic or sonographic guided percutaneous or minimally invasive surgery. I know you're going to really enjoy this episode, and these gentlemen are just really incredible with what they do. So please enjoy this conversation with Dr. Iborra and Dr. Villaneuva. Good morning, gentlemen from Madrid. Thank you for joining me today. I am super excited to have you guys on the show, and really honored not only to have you on the show, but to be able to have worked with you guys in the past. And what you're going to share with us today, I think, will just resonate with the audience because it is so cutting edge. You know, when I first saw you guys doing this a few years ago, I just had to scratch my head and take my hat off to you and bow to both of you because what you're doing is extraordinary. So thanks for taking the time this morning to join me and share this with the audience. And so do you guys want to talk about plantar fasciopathy or plantar fasciitis first and your ultrasound technique? Or maybe before we get into that, why don't you tell us how you started doing this and when you started doing this? Can you give us a little bit of history on that?
This is a little bit personal, sorry, maybe because of my age, but the history behind the history is that Alvaro opened to me the vision of musculoskeletal system through the ultrasound in a lot of more than 1 decade ago, because he was used to use the ultrasound, and he has an extraordinary capacity to look not just ahead, just to look in 360 degrees around. And for me, a classical form orthopedic surgeon, this was like the new world. I could reach and see structures that usually require an open surgery, limb sanguination, and at the end, the surgical gesture was not so complicated. So the question was to be sure and to be precise that we could do without opening. And this is the way we meet each other, and we decided to start working in cadaver surgery. We were working in cadaver surgery for more than 2-3 years, doing a lot of procedures. And the real history is that we did a lot of investment in that. That's not common in our country because usually doctors or podiatrists or professionals are rather the investment of a company with another interest, with their own interest. So we invest in our own knowledge and learning, and we were able to develop many surgical procedures after training in cadaver.
Okay.
And we started to do like 15 or 20 surgeries, and we opened the cadaver, the specimens, and we checked that we had not damaged any structure, and we have got the goal of releasing a structure or doing what we pretended to. And that's the real history. So we were expanding a little bit the ideas, not just our own ideas, we can talk about that later, but just the ideas of many pioneers like you or any other doctors who have from 30 years ago, like Dr. Nakamichi, 30 years ago, he stated the basis for release of the ultrasound of the carpal tunnel syndrome. Other podiatrists in the United States have described how to release the plantar fasciotomy. So we were adding our own modifications, but the basis for this surgery were there. The question is that usually people is not used to work with the ultrasound, even they don't have the ultrasound in their office or in their clinical practice. And the other point, at least in our country, that people is not decided to do a lot of personal investment in terms of money, time, because you don't know if you are going or not to be able to get the real the scientific, clinical, and monetary reimburse of that investment. And that's our story from more than 10 years ago. There were some basis for this kind of surgery from real pioneers as soon as 30 years ago. And other doctors 10 years ago started to shake it a little bit. There was a renewal of interest in this kind of surgery, and we consider now we are being part of a boom of interest in this kind of surgery.
Now, when that's very good, and I think that's the fact that you spent that much time in the cadaver lab says quite a bit, because there's a definite learning curve to any of these minimally invasive types of procedures, and I think that the more time you spend in a cadaver lab, when you start clinical implementation, that just helps you so much, because you have that experience from the cadaver lab that you can translate into clinical setting. Did you find that of the several procedures that you all are doing with ultrasound guidance, was one more difficult than the other? I would assume that the tarsal tunnel decompression was the hardest. But the plantar fascia and the gastroc probably were, I don't want to say simpler, because they're not simple techniques, but they had to have a lesser learning curve than the tarsal tunnel work that you are doing.
No. For sure, tarsal tunnel is the most difficult to treat and the most difficult even to diagnose. Mm-hmm. You are part of these studies, and you've been as well our support and inspiration to develop new techniques, some of those based on ultrasound, to better diagnose the tarsal tunnel syndrome. And it's the most complicated, just even the comprehension of the bifurcation of the distals, of the two distal tunnels. The distal tunnel is the most difficult part, and probably that's in the base of why this surgery, at least in Europe, is partly abandoned, because people only release the proximal part, the lacinatus.
They're not releasing the cause of the problem.
Correct. They are not releasing the most frequent cause of the problem. And for sure, Alvaro always says that we were close to give up in some parts of this research, because we tried to do the releases, and when we did the dissection of the specimens, of the cadaver specimens, we were not releasing what we wanted to, or the release was not complete. And so it took us a lot of months, and for some time we were a little bit disappointed.
Right.
But we were getting more and more familiar, and at the end we were able to get the release that now we are doing. That doesn't mean that 100% of the patients get better, because
Right.
there are more elements maybe in the central system or things that we are not able to understand, not just the release, the dynamical compression or whatever that we still can properly understand. But this was the hardest part. For example, some of the procedures that we published and described in the past years are really, really simple. And once you are used to the use of the ultrasound to learn how to release the iliotibial tract or a lateral snapping hip, or now the Dupuytren's disease, it only takes you several cadaver specimens or several weeks to get the proper training. It's not so hard. For sure, probably the easiest procedure is the plantar fasciotomy.
Yes. So let's go ahead. I know you guys have some wonderful videos that you want to share. Let's go ahead and click on that, and let's talk through it, because I think seeing is believing.
Okay. We'll start with converse. We'll start with plantar fasciotomy.
That would be great. Yes.
And we'll go later on to the tarsal tunnel.
Okay.
When we presented all these videos to the American Academy of Orthopedic Surgeons, are actually included in the educational media program, so everybody can join and quick and accelerate its learning phase with the help of these videos. But it's still a difficulty to teach people the correlation between the images of the ultrasound and what you are doing. So we try to reinforce the videos with the 3D mini videos in all our works, as you can see. This is the way we started. The quality of this equipment was not so good as the ones we are working with currently. And you can see the positioning of the hook. You can even see the hook knife. And there are several tricks that we try to explain carefully in the videos, like putting all the structures under tension is basically, otherwise you won't do a perpendicular cut of the structure you want to release.
Correct.
That seems stupid, but it took us 9 calibers until we learned that basic thing with the lateral snapping hip. We were trying to release the proximal iliotibial band, and after 9 calibers, getting the release in an oblique way, we realized we needed longer pieces with the entire side until the knee, because we needed to put under tension the structure. Otherwise, we were not able to cut, to control the direction of our cut. It's a simple thing, but it's basically in all these releases guided by ultrasound. In the case of the plantar fascia, we are used to work together from the beginning. And one is usually, if I'm putting the foot in dorsal flexion, I keep the probe, and Alvaro concentrates in positioning the hook knife, or now that we do this just with the avocat, just with the tip of a big needle of an avocat without the hook knife, and he's concentrated in that maneuver and the positioning. But when you use a hook knife, one important thing is to to rest your hands, one over the other one, or just on the table or on the surgical table, to avoid a vigorous or uncontrolled movement that will cut the skin. So usually we advance just the distance of what we can do, just flexing our fingers. This is the way we do this procedure currently. We make like multiple perforations with the tip of a needle, with the tip of an avocado, with a 16 millimeters gouge. And the tip of the avocado is like a knife, the bevel. It really cuts. And we do multiple perforations, and after that, you do like levering movement, and with that levering movement, we feel the final cut of the plantar fascia. These are some of the cadavers we use, and we are here checking in the cadavers at the beginning of our training that we were capable to do what we pretended to without damaging any structure.
Now, how do you all manage these post-operatively? Are you letting them immediately weight bear? What's your protocol after surgery?
You've seen this patient walking with a negative heel, so the negative heel shoes. So to avoid pressure for 2-3 days, not longer.
Okay.
Over the operated area, over the area of the heel. After 2-3 days, depending on the comfort of the patient, we allow them to change to normal sport shoes or running shoes, and that's it. It can range from 2-3 days. At the beginning, we used to keep them with this special insole for 1 week, and now we've been shortening a little bit the.
Do you find
period?
When we first started doing endoscopic plantar fasciotomies, of course, we released everything, medial, central, lateral band, and about 9%, we published a study, I think it was about 550 approximately patients, and multiple surgeons were involved in that study, and there was about a 9% incidence of calcaneal cuboid syndrome or lateral column destabilization. Once we only started releasing the medial band, that dropped down to less than 3%. What's your experience with that complication with this particular technique?
Pretty much the same, because at the end it's a matter of redistribution of forces and bearings.
Right.
So, Alvaro, what do you think? 3% of patients have the lateral syndrome by overweight. We try to wait at least 6 weeks before proposing the patients an insole. We wait until the pain in the area of the release reduces, and then the patients do a more normal step and more normal weight bearing, and usually the pain in the lateral column goes away after maybe 6 weeks, 12 weeks, and it's really, really unusual that patients have pain longer than, I'm talking about this 3-4%.
Yes.
That patients have pain longer than 2-3 months. That's quite unusual.
I understand. Yeah, that's the same thing we saw. You know, if we had somebody, they were so happy that their heel pain was gone, their plantar fascia pain was gone, that they just wanted to be super active, and they just couldn't do that until that fascia refibrosed in a longer position. And if they were too active and they were out running or hiking at 2 or 3 weeks post-op, that seemed to be very problematic. So we kind of would sit on them for at least 6 weeks, sometimes a little bit longer, especially if they were starting to develop some signs of it, maybe at week 2 or 3. You know, we would back them off their activity.
All of the sponsors of this podcast are listed on the website at podofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000, but you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been. That's wonderful. I mean, this is a very eloquent surgical procedure. The way you guys do it makes it look extremely easy, and I can assure the audience this is very difficult. It's high level, and it requires a lot of training and expertise like you all have done. Do you want to show us the gastroc, or
we'll show you more procedures.
Okay.
This is the gastroc release. We can go later on with many procedures in the Achilles tendon, how to perform micro punctures, releases, and the opening of the paratendon is also included in these videos that are in the educational media of the EOS program, and we can go further with later with the tarsal tunnel syndrome. This is a really, really nice procedure. In this case, the indication was for a non-insertional Achilles tendinopathy.
Mm-hmm.
And basically what we do is a Strayer procedure.
Okay.
So we select the incision, the approach to 2.5 centimeters distal to the distal head of the medial gastroc. That's the selected point. And what we see in the dotted line is the sural nerve. Sural nerve is the only structure that you have to protect in this surgery.
Yes.
So we create like a highway by hydrodissection underneath the sural nerve.
So you are deep to the aponeurosis now?
Yes,
is that
we
correct?
are deep to the aponeurosis.
Okay.
And we usually, if the patient has a big calf, you rather should do 2 portals in order to avoid just like levering too much the first portal. Otherwise, you have like skin tears. So rather 2 portals of 1-2 millimeters than 1 of 5 millimeters, because you've been levering so much the portal to cross until the medial part of the Achilles tendon. Maybe you need to do a hard or vigorous levering, and that can tear the skin, because the approach to this surgical technique is located in the lateral part, because we need to stay underneath the beneath the nerve, and that's the only
Right.
the only delicate, the only critical point.
Yeah. So, I mean, the sural nerve just seems to be very variable as well in that area. I mean, you can have it be in several branches, and you can have, I've even seen it in the cadaver lab where the sural nerve is actually almost invested in the aponeurosis itself, where it's just really, really tethered down to that tissue. So that's one of the things that we encountered with the endoscopic gastrocnemius recession was always, super care of the sural, because it's a nerve that if you cut it, many times it's not really very happy about that, for sure. It can cause people a lot of problems. That's wonderful. So what is your thought process on the gastrocnemius release or recession versus the plantar fasciotomy for somebody who's had heel pain? How do you decide which procedure you want to go with, or maybe sometimes you go with both? What's your thoughts on that?
At the beginning, for non very stiff gastrocs or severe contractures, we try to do some proximal medial release, selective proximal medial release. That procedure was popularized, at least in Europe, by Dr. Baruch, that in reality is half of the procedure that Filbert Fiol described one century ago.
Right.
And as Dr. Baruch is a leader opinion, many surgeons are following his advices and are doing a proximal medial release. The intention when we described this technique was to shake up the brains of all these professionals and telling them, okay, you can follow the advice of a prestigious doctor like Dr. Baruch, but you don't need to open to do this. Mm-hmm. Currently, as we recently described, Dr. Iborra described in an elegant work in the cadaver, that we can do the same that we were doing with the hook knife, just with the tip of the avocat, with the tip of the needle. We are doing or complete release in the operating room for patients with severe echinus or patients with cerebral palsy or things like this. We do still a complete release for these patients with a surgical knife, with a surgical hook. But in patients in the clinic with not so hard contractures, we rather to do in the office just with the needle in the same way we described with the Dupuytren's disease or with the plantar fasciotomy, limited gastro release. So we can check step by step the degrees of release that we get. And in this procedure, we can do from the medial part to the lateral part and try to avoid staying in the area of the sural nerve. Mm-hmm. So our current practice has evolved, and now we do a complete release in severe patients with bilateral or severe contracture over 15 degrees, or patients walking on with severe echinus feet, or in patients in which we have or we've identified a non-insertional Achilles tendinopathy or a mild contracture from 10 to 15 degrees. We rather to do with the tip of a needle with local anesthesia in the office. And just doing part, not the complete striate release, but part of the striate release.
Okay. Manuel, do you feel that with the needle, it's less invasive than with the hook?
With the? It's the same with the needle.
With the needle, do you feel it's a little bit less invasive than with the hook knife?
Yes, it is. With what we've observed in patients with cerebral palsy or ¿cómo se llama la enfermedad esta? No, see, with young patients with neurologic disorders, is that when we do the complete release with the hook, for sure, even in a minimal way, will damage some fibers of the muscle. And the patients usually have pain. And the first 2-3 days, it's difficult to them to start walking. But after 2-3-4 days, they notice, they realize that pain is perfectly manageable and they start walking. And that's amazing. It's like a miracle. After 3-4 days, patient that came into the in the operating room, walking on their toes, start walking with a flat feet. With the needle, for sure, we are less invasive and we can reduce the damage of the muscle, but probably it's not the perfect procedure in real severe cases. But this is still, if you have the time, you have the patient, and you have the training, it's a more delicate procedure, and the patients in which perform this kind of gastric release, they almost don't have pain. They almost take 3 pills in the following days.
That's wonderful.
And there is an additional advantage, because here in Europe, we are, and in Spain, we're like you were 30 years back. And sometimes podiatrists are like crashing against a wall because they have some certain restrictions. And if you are able to describe a procedure in an anatomical area where podiatrists are not going in any country in the world to have any restrictions to perform that procedure, that surgical procedure, is also an additional advantage, because now Alvaro is like in a tough fight against the system, the authorities, and the mentalities, like in the medium age with other things, and like the fight you had 30 years ago in the States to right. Get you have the knowledge, you have the technique, you have the training, and you have all the knowledge, but sometimes it's difficult that the authorities understand that you can do surgeries in certain areas of the skeletal system, of the skeleton system, better than orthopedic surgeons. So this is an additional advantage, because more in Spain there are many podiatrists that are doing the proximal gastrocnemius release, and they are not, in theory, they are not allowed to do that, but they are doing, because they are following the advices and the teachings of Dr. Barrett. So if we provide them with a surgical technique that is easier to do, that you can control, because it's a little bit a la carte. You can do, how do you say it? You need more release, you go further, you go more lateral.
Right. Well, that's one advantage with a gastrocnemius procedure. Even if it's open, you can see how much dorsiflexion you're getting right there for that patient on the operating room table. So it's not one of those things where you kind of have to just do the procedure and wait and see. You can actually see intraoperatively, did I get enough release? And if you haven't, then you release it a little bit more. So I think it's a very precise procedure from that standpoint, because you can get very accurate intraoperative measurements. Wonderful. Do you want to talk about some of the other ones now? I mean, I'm fascinated by this. You guys are tantalizing us.
Do you think it's good to, because there are only 20 minutes left, to go to the tarsal tunnel syndrome?
Why don't we go to the tarsal tunnel syndrome? But before we do that, let's talk about that wonderful paper you just got accepted and published in Frontiers in Neurology, because I think that's really, I mean, you made the comment earlier about the diagnostic challenges of tarsal tunnel. I think, first of all, congratulations on the paper. I think it's wonderful. I think it's going to make a difference for a lot of people to be able to diagnose these. And what you were able to show with the Electrodiagnostic changes, very objective. That's not just a subjective finding based on the patient experience.
Okay, there are two diagnostic tests guided by ultrasound, and we can offer to our patients. One is to measure the pressure of in the tarsal tunnels, but not the machine to measure the pressure is not widely available. Even now, it's difficult to get. Even here, maybe even in the United States, not all professionals are going to have that machine. What is much more interesting is this paper, in which we started to help the neurophysiologists to position the needle with the ultrasound, because there is a wide variability in the tarsal tunnel, and many times they don't know properly where they placing their needles before to do the register of the nerve. Mm-hmm. And once we started to positioning the needles guided by ultrasound, a lot of patients in which the diagnosis was there is no nerve compression, it changes dramatically. Here is at the beginning, Alvaro was placing all the needles for the neurologist until the neurologist was becoming more and more used to do, and now she does, the Doctora Celaya does by herself. But at the beginning, in most cases, Alvaro, occasionally I did also, we help her to positioning the needle close to the nerve. And when she did the test by herself without ultrasound positioning, many patients had apparently non-compressed nerves. And we started to do this, the register changed dramatically. We consider that for the future, this may be probably one of the things that is going to change the practice of many doctors most, because I consider this pathology has been undertreated because you are not able to diagnose it. So
that's a really wonderful point, because there are still some people that believe that it doesn't exist, that tarsal tunnel syndrome is non-existent. And it's pretty interesting how many of these cases there are out there that are, truly clinically present, that have negative EMG findings, and for different reasons. And I don't want to necessarily get into that too much because our time's somewhat limited. But the answer is that there are a lot more of these cases than people believe.
Steve, we always say in our conferences or when we explain to the patients, you think of it, carpal tunnel syndrome is considered the most frequent peripheral nerve entrapment, and probably is the most frequently diagnosed and surgically treated. And it affects 2 to 3% of patients in the entire life. But as you know, 10% of the patients will suffer heel pain along their lives. And if you consider that many of these patients, probably barely less than half of them, 5%, will be plantar fasciitis. This many times a clinical, not ultrasound or MRI diagnosed, just clinical diagnosed. If you consider that probably only 5% of these patients will have a complete or a mixed syndrome, mechanical and neuropathic syndrome, we are talking about 5%. So probably we are facing a silent epidemic, underdiagnosed, and probably we are facing the most frequent peripheral nerve entrapment, tarsal tunnel syndrome.
Right. Very, very, very apropos to what you all did with this recent paper as well, because being able to understand that a focal nerve compression will have focal neuroischemia, and if you are able to put any type of a vasodilatory agent next to that focal entrapment, you're going to get temporary improvement in perfusion of that nerve, and you'll see increases in function. This takes the guesswork out of it right there and then, regardless of whether or not they may have other proximal nerve compressions. They may have a double crush or a triple crush situation. You're able to assess how much is that contributing at that focal area to that patient's problem. It's very powerful. And the nice thing about it is that it's not really super expensive. There's not a, there it is. There's that great paper that y'all wrote. And, you know, so this is something that can be done almost by anybody. I mean, because if you think about it, lidocaine is not really expensive. I mean, yes, you do need some ultrasound technology, but it's not like an MRI, which in tarsal tunnel rarely is helpful unless you have an intraneural ganglion or some space occupying lesion. I guess an MRI will give you some insight as far as how much denervation of the muscles are occurring. But this is something that can be done. It's very translational in your clinic. You can do this very quickly, and patients can see the result right away. And that's a powerful thing.
If you've touched us, and we know that you've been teaching this Phoenix sign to many clinicians and many podiatrists and doctors in the States. And Alvaro was always telling me, we owe this to Steve. We owe this to Steve. We need to register this. We need to understand this because this has changing, and many clinicians are using this test, but we need to understand why. So that was the inspiration. As you know, you've been part of this work, and it's been really, really amazing because now we have like one more, the second step. The first was the knowledge of the Finnish sign and the Finnish test. You touch us, and now we have like the registration using these ultrasound guided techniques for neurophysiology. We have like the evidence or the measure of this sign with the use of subanesthetic dosage of lidocaine. And as you say, many doctors use this, podiatrists use this in their clinical practice. The question is that from now on, we could establish or study for ranges of improvement of the nerve with the use of this minimal dosage of lidocaine, and we could use like prognostic scales or to use it like a prognostic test for future surgery. So this is like the second step, but we don't know where the steps will finish, will end.
One thing that we have done, we just submitted it for publication, and we did a randomized prospective double-blinded study comparing papaverin to lidocaine. As you know, papaverin's a very known vasodilator, been around for many, many decades, actually. And we did not see any difference clinically between the lidocaine and the known vasodilator papaverin. So I think that confirms strongly that this is a vasodilatory phenomena. And, you know, so from a hypothetical situation, it kind of puts to rest any notion that it's a property of the anesthetic portion of the agent. It's really just a vasodilation situation. You're getting more blood to a thirsty nerve that's being squeezed is really the way that I put it. Well, let's talk about, and the prognosis is very good. We're actually working on a prognosis paper right now that hopefully we'll be able to complete that study enrollment in the next several months. But let's talk about your technique now for the tarsal tunnel, because I think this is not only surgery, I think this is artistry.
it's difficult to explain as well. So we use a lot of colors in the video and the 3D image that sometimes it's the basically we do like a mapping of the nerves and the vessels, and we try to delineate the track of the nerve with the ultrasound. We create like acoustic shadows with the ultrasound, and after doing those acoustic shadows with the hollow tip of syringe, we do some marks. You see the marks in the skin. We work in the delineation of this. This was the first part of our work. So we first delineate with the ultrasound the tract of the nerves. And then here you can see the structures, and usually we try to go posterior to the tendons and anterior to the neurovascular bundle.
And this, you're hydrodissecting a little bit?
That's the flexor retinaculum and the beginning of the abductor. Here there is like an anatomic limitation because in many patients the calcaneomalleolar vein is in the midway of the tract, so we need to stop there the release tract. Sometimes we cut it and we need to put a lot of adrenaline and keep on pressing for 2-3 minutes until we are able to get the collapse of that vein. So here we use the same surgical technique in all the procedures. This was our way of work since we described in 2016 the gastroc release. We always use the podiatrist curettes, number 1, number 2, and you can use the hollow part, the cannulated part, to guide over the syringe and the needle and the long needle. Here you can see on the left side the tibial tendon, the flexor tendon, and we are enlarging with anesthesia or with volume the space between the tendons on the left side and the neurovascular bundle. Now the cursor is over the nerve. It's quite common, the image of the Mickey Mouse head because of the artery and the veins. But many times the veins collapse just with the volume because this structure is under pressure, and in patients going for surgery, probably the tension of the structures is even greater. And when you put the liquid, when you put the anesthetic, sometimes the vessels collapse. And we stay in that working space in the same way that Dr. Nakamichi 30 years ago described the Nakamichi's narrow. I always joking with Alvaro, telling this is Iborra's narrow. It's like a map, this narrow space, but you can enlarge with the volume. It's important to rule out any accessory muscles, because if you are sure that you have accessory muscles or vascular braids, or maybe this is a limitation for ultrasound guided surgery, because you won't be able to do a complete release of the nerve. You'll be able to release the ligament, but you won't be able with ultrasound surgery to release the vascular brace or to reset the additional or the extra muscles, the accessory muscles.
Mm-hmm.
This is the normal surgical technique. We are now working in the proximal tarsal tunnel, and the limit for this is the abductor, or maybe a little bit behind the abductor, and that's the limit for the first release strut. You can see the hook. We rather to point the hook knife towards the tendons rather for sure than towards the neurovascular bundle. Right. So always anterior, not posterior. Then when you turn, the pressure sometimes is really, really high, and it's difficult for the surgeon to keep perpendicular the hook knife. But that time, the assistant will put under pressure in dorsal flexion and eversion the foot. And once more, you need to rest your hands on the surgical table and try to advance in a controlled way to avoid like a long wound and a skin tear.
Mm-hmm.
You can see here even the hook of the knife. And training is important because this is not a surgery you can say, okay, I'll do the first one in 2 hours, the second one in 1.5, and after 10 surgeries, I'll do in 1 hour. Because maybe you won't be able to complete the first one because the ultrasound image is getting worse and worse because of the gel, the betadine gel we use, or maybe because of the air bubbles. So there is like a distortion of the ultrasound image. Now we are checking the proximal part is released.
Oh yeah, very nice.
We did this surgery in New Orleans, and some podiatrists did the surgical release, and they checked it was completely released several years ago. And this is the most difficult part. This is the 3D representation. Here you can understand what we are doing. And we need a second portal now in some cases because we need to preserve the calcaneomalleolar vein that is crossing the natural path of release. And because the medial plantar nerves at the bifurcations of the two plantar nerves, the medial plantar nerve, sometimes you can do with the same proximal approach. You can do the entire tract with just one proximal approach, but you cannot do the lateral plantar release usually with the proximal approach. So you need to do two approaches, two portals. Here you can see we are beneath the muscle. Sometimes the image of the muscle in patients with large time compressions is gray and pale. It's not this image. You see a really, really damaged muscle, an ultrasound image that in which the fibers of the muscles are distorted. And what you need to check here is that one release strut is medial and the other one is lateral to the T.
Mm-hmm.
To the septum.
Yes.
Usually here we use some lidocaine with some adrenaline and inject a little bit in the muscle after the release to avoid the bleeding. Because for sure here some minor fibers of the muscle or minor vessels can be damaged. But with the use of anesthesia or lidocaine with adrenaline, you'll be able to control the bleeding, and most patients only have minor hematomas. We use like a long palpator, or
like an elevator?
Like an elevator, yeah. And with this elevator, you can see in the upper part of the image, at the beginning of the surgery, before surgery, we are not able to do the levering movement, and after the release, we are able to do the levering movement. Here you can see this is the release of the medial nerve. And the same steps are done for the release of the lateral plantar nerve. One is medial and the other one is lateral or posterior to the septum. And then and in the lateral, the Baxter nerve does not require a specific release tract. It goes with the plantar lateral nerve. Yeah, it's in the same. Yeah, it's in the same path. It's in the same posterior camera, posterior area. This is 3 months. And once more, like in any other kind of surgery, like plantar fasciitis or even a total knee arthroplasty, this kind of surgery, minimal invasive surgery, will improve the recovery of the patients, will reduce the consumption of painkillers. But so far, it's not proven that in the mid or long term, the results are going to be superior. What for sure is superior is the reduction in skin complications, and in patients with neurovascular or with vascular problems, you are reducing the risk of wound descenses or things like that. But so far, honestly, like in any other minimal invasive surgery, there is no evidence that in the mid or long term, the results are going to be superior. But for sure, there are differences in the first weeks or first couple months.
Well, I think that you will have much less likelihood for post-operative excessive fibrosis because of the minimal invasiveness of the procedure.
Sure.
There's always a component of skin dehiscence or wound dehiscence in open tarsal tunnel procedures, and you kind of obviate the development of that. So those clearly can have long-term ramifications. I mean, I see 1 to 2 patients a month that are in for a revision tarsal tunnel surgery, which I can't think of anything harder in the lower extremity to have to do than a revision tarsal tunnel. And you know, these folks are tremendously fibrotic. So empirically, you would have to be on the side or on the belief that, yeah, I mean, if we're doing it with a lesser invasive technique, the ultimate outcome has to be somewhat better compared to a large scale of open techniques. But like you say, that there's not really a lot of clinical studies that are going out there 10 years and comparing them with the control group that had the open. So that's a wonderful procedure. What would you recommend for people who want to develop expertise in this area? Obviously, you should start with cadavers, but I think the number one thing would be to be very adept in ultrasound interpretation.
I think the basis is to buy a nice ultrasound. So it's cheaper to buy expensive ultrasound and be sure that what you are interpreting or what you see is what you really see, that buying a not so good ultrasound and trying to compensate with more patients or more cadaver dissection.
Right.
I would say that it's rather if you spend double in the ultrasound than not double in the surgical training.
Yeah. Well, it's hard to be an astronomer without a good telescope.
Sorry, Steve. Alvaro intelligently has put a comparison between the first ultrasounds we used and the new one.
Yeah.
On the left side, you can almost distinguish the structure. You have to guess, not to see. And on the right side, you are sure what you say.
Right. I mean, people sometimes, if they really want to become world class, they have to buy world class equipment. And I mean, those two pictures there, it doesn't take much of a radiology background to interpret that. I would clearly want to have the one on the right.
Mm-hmm.
So,
sure.
Wonderful. Well, gentlemen, thank you so much for sharing this. I look forward to hopefully crossing paths with you guys, and either that here in the United States, or I will be coming to Spain in the future, and I would, look forward to that quite a bit. I always like hanging around with you guys, and I learn so much when I'm with you, and so I want to congratulate you both for the work that you're doing. It's extraordinary, and just thanks so much for taking the time to join me on the show today.
Thanks to you for the inspiration and all these years. It's been an inspiration to work hard in this area. Thanks for your consideration, and sorry for our English to the rest, to you and the rest of the people.
Well, I wish my English was I wish my Spanish was half as good as your English. So thank you guys. Appreciate you so much.
Thank you so much. Thank you.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.